تمام. So again, Assalamu alaikum. My name is Shahd Alheijani. I'm a third year student, and I'm very excited to be giving this last session. Um, so today's lecture is going to be about heart valve disorders and murmurs. This is a CVP session, CVP lecture given by Dr. Simon, and in this lecture we'll be covering the normal heart sounds, then we'll move on to the abnormal heart sounds and murmurs. Moving on finally to the valve pathologies, the stenosis and regurgitation and how they affect the PV loops, and finally to questions. We'll have a couple checkpoints throughout the presentation, but if you feel like you need to stop me throughout the presentation, feel free to do so, please. So we can get started. So before getting started, since this lecture is going to be about valves, I want to know if you guys have the basics. So first, let's start with the very basic. What is a valve? Can anyone type in the chat or open their mics?
Which prevents backflow of blood.
Exactly, thank you. So a valve is a structure basically that prevents the backflow of blood, for example, between the atria and the ventricle, or the ventricle and the aorta, for example. So let's point at the valves. So starting with this valve, can anyone tell me what this valve is? Okay, wait, let me open the laser pointer. Easy. Okay. So this valve is between the left atrium and the left ventricle. This is the mitral valve. So what is this valve?
Tricuspid.
Exactly, the tricuspid valve. And then we have this valve.
Aortic semilunar valve.
Exactly, the aortic valve. And finally, we have the pulmonary valve. So the mitral and the tricuspid valves are between the atria and the ventricles. So they're called the atrioventricular valves. Meanwhile, the aortic valve and the pulmonary are both the semilunar valves. Is that good so far? So now we can move on to the auscultation. Auscultation is basically listening to the heart sounds by a stethoscope in the chest. So this is a picture I got from osmosis, but yeah, we have a mnemonic here to remember the arrangement, but feel free to use any other mnemonic you want. So here we have the mnemonic ape to man, starting with from the top to the bottom. So starting from the second intercostal space till the fifth. From the second intercostal space, we have the aortic and the pulmonary. The aortic valve is auscultated in the second intercostal space on the right sternal border, and then we have the pulmonary on the left. And then we can ignore Erb's point, we just care about the valves for now. So we have A, P, and then tricuspid in the fourth intercostal space, in the left sternal border. And finally, the mitral valve at the fifth intercostal space, but this time at the mid-clavicular line. So this is the clavicle, this is the mid-clavicular line. This point also has the apex of the heart. So this is where the mitral valve is best heard. So this is all for auscultation. Is that clear so far? Can we move on?
Yeah, just can you explain Erb's point or?
No, Erb's point is not relevant to the auscultation. It's something totally different, so we can ignore it for now. Just focus on in the valve locations.
Okay.
Okay, so this is Wigger's diagram. Wigger's diagram, as you probably know, shows the changes in the pressure and the volume happening in the chambers of the heart, the atria, ventricles, and the aorta during each cardiac cycle. So, for example, you have this green line here. This stands for the ventricular pressure. So you can see there's a huge change in pressure because it's pumping blood all over the body. Then the yellow line here is the atrial pressure, because the atria will only be pumping blood for a short distance, so it's only a small bump, small rise. And finally, the red line would be for the aortic pressure. Okay, why are we talking about Wigger's diagram here? So basically, we want to know about the heart sounds, the valve sounds. So at this point here, can anyone tell me what's happening in this curve? Does anyone know?
Atrial depolarization.
Exactly. So atrial depolarization, or what is happening in the pressure here, is due to the atrial contraction. So the atria get depolarized, and then we have atrial contraction. So after the atria contract fully, and the ventricles are now full of blood, the ventricle will start contracting to push this blood out. So when the ventricles start contracting, here we have a valve closure. So here we have which valve is closing at this point? The atrioventricular, the mitral and the tricuspid valve will close because the ventricles want to pump blood outside the heart. So here we have the first heart sound. Okay, so now we can start by introducing the heart sounds. Heart sounds are heard when the valves close or open. Can anyone tell me? Does anyone know?
Close.
Exactly. So they coincide with the closure of a valve, but the heart sound itself is not a result of the closure itself. So the heart sound is a result of the vibration of blood in the chambers, or the stretching of the walls, the vibration of the blood and the tendons. But the sound is heard during the closure of the valve, but is not a result of the closure itself. Is that point clear?
Yes.
Tamam. So here we have the first heart sound, which is due to the closure of the atrioventricular valves. Now, as you can see here, the sound is the, which is the first heart sound, due to the AV valve closure. Now, the ventricles will contract. Here we have isovolumetric contraction, and then the semilunar valves would open. Opening of a valve does not have a heart sound. So here we have the first heart sound. There's no heart sound. Now, the valve is open, and the heart will push blood outside through the aorta and the pulmonary artery. And here, after the pumping is done and the ventricles will start relaxing, the semilunar valve would close. Now, this coincides with the second heart sound, the dub. So we have first heart sound with atrioventricular, second with the semilunar. So we have atrioventricular for S1, semilunar we have S2. Okay. Now the ventricles will start relaxing and filling with blood, and will continue. So the two normal heart sounds are S1 and S2. Now we also have pathological or abnormal heart sounds. We have S3 and we have S4, which we'll be discussing shortly. So here we have the heart movements. So we said S1 is when the ventricles start contracting. So the mitral and the tricuspid valves would close. The ventricles now contracted, pushing blood outside into the aorta and the pulmonary arteries. Now, when the ventricles start relaxing and they would just start filling with blood, the aortic and the pulmonary valve would close, which is S2. Now, S3 here is heard just after S2. S3 is the first additional heart sound we have. So when do we hear this sound? We'll be discussing all the details shortly. But for now, I want you to remember that S3 is related to volume overload. So if we have excessive volume, we'd hear the S3 heart sound. So this is due to the rapid ventricular filling phase. We said here the heart started relaxing. Here the heart started filling with blood. So this is when we hear S3. S4 finally would be heard here just before S1. This heart sound, this fourth heart sound, is heard when the atria start contracting. So atrial systole. So when the atria start contracting, we hear S4, and this is due to pressure overload. Again, I'll be getting into the details shortly, but for now, just remember this. Checkpoint. Everything okay so far? Do I need to go over anything again? Okay, I'm assuming everything is good. I can move. So first we start with explaining the normal heart sounds. S1. We said S1 is heard due to the closure of the AV valves, the atrioventricular, which are the mitral, and the tricuspid. So we have two valves closing, giving us S1. Sometimes you can hear a split sound. So instead of hearing one heart sound, you would hear two for S1, a split sound. So sometimes this can be normal in some cases and abnormal or pathologic in other cases. So when is the sound normal? This is normal when the valves don't close at the same exact time. In other words, the closure of the valves is not synchronized. So what happens here is that the mitral would close just a bit before the tricuspid. Now, this is due to the left ventricle getting excited just milliseconds before the right ventricle. So this is the left ventricle. Let's say the wave of depolarization reached the left ventricle just milliseconds before the right ventricle. This valve would close first. And what did we say this valve was? This is the mitral valve. So the mitral valve would close just milliseconds before the tricuspid and would give us a split S1. Now this is normal. What if there's a pathology? What if there's something abnormal? this would be seen in the problems in conduction system of the heart. So what's the conduction system of the heart? It starts by the SA node, and then you have the AV node, you have the bundle of His, and so on. So the bundle of His would divide into branches. So we have the left bundle branch, right bundle branch, and so on. If we have any block in one of those branches, the wave of depolarization would be slowed down. So let's say in this branch, this is the right bundle branch. Let's say there's a block here. The wave of depolarization would reach the left ventricle before reaching the right ventricle. So this would cause a delay in the contraction, a delay in the closure of the valve, and so on. So this is called a bundle branch block, left bundle branch block or right bundle branch block. But point is, there's a problem in the conduction system. So again, S1, split sound could be normal if if the closure is not synchronized. Abnormal if there's a problem in the conduction system. Now, what about S2? S2 is due to the semilunar valve closure. We said semilunar valve, second heart sound. So again, we have the aortic and the pulmonary valve closing, giving us the S2 heart sound. Now, sometimes you'd hear again a split sound. This could be either, again, physiologic or pathologic. When is it normal? It's normal when the aortic valve closes before the pulmonary valve. And one important thing you should remember about S2 is that if in a normal split S2, it would be enhanced during inspiration. Why is that? Oh, let's look at this diagram. So this is the chest rising and falling during breathing. This is during inspiration. What can you notice during inspiration? What's happening to the volume inside the chest? You can type in the chat, you can open your mics. Okay, during inspiration, here you can see, during inspiration, the diaphragm is going down. So when it's going down, there's increased, there's chest expansion. So you have a lot of increased volume. So what happens to the pressure inside? The pressure inside the chest would fall. Intrathoracic pressure would go down because the diaphragm is going down. You have more volume, the chest wall is expanding. So the pressure is falling. Now, how would this affect us? Let's look at this diagram of the heart here. So you can see the blood is going through the inferior and the superior vena cava into the heart, and then it goes out through the pulmonary arteries, again through the left side of the heart. So if we have decreased intrathoracic pressure, we would have increase in the venous return. So now we have, let's imagine there's a decreased pressure. So you can imagine as if less structures are pushing on the heart. So now more blood can rush into the vena cava. So we have more blood flowing through the vena cava into the heart. And now, how does this affect us? How does it affect the valves? We have more blood going in. So more blood would flow into the right side of the heart, which is the right ventricle. So the right side of the heart would be taking time to fill up, while the left side of the heart, خلاص, and the blood came in, and the heart is contracting. The heart now started relaxing, so the aortic valve would close. Meanwhile, the right side of the heart would still be filling with blood, so the pulmonic valve would take longer to close. So now, again, the aortic valve would close before the pulmonary valve, and that is enhanced during inspiration. So the S2 heart sound would be split. You would hear the aortic first, and then the pulmonary valve. Is that clear? No? Okay.
Yes, one question. Can I ask?
Yes. Of course.
Can S2 not be split sound? Just one.
Yes, normally S2 is only one heart sound, but sometimes you can hear it as a split heart sound. It could either be normal or abnormal. So usually you'd hear it as one sound, but sometimes if during inspiration, for example, you'd hear it as a split sound, or in some abnormal cases, which I'll be getting into. So,
Thanks.
okay. So when is it abnormal? It's abnormal if we have a bundle branch block, as I explained in S1. Here we have the conduction system of the heart. If one of the bundle branches is blocked, there will be a problem with the conduction, and again, one valve would close before the other. So now we have a split heart sound. We also have split S2 when there's an atrial septal defect. So what is an atrial septal defect? So basically you have an opening between the atria of the heart. So you can see here, the septum between the atria is not fully closed. So you have an opening, so now the blood can go from the left atrium to the right atrium. Now you can imagine it as the same concept. So now more blood is flowing through the right side of the heart. So more blood will be going to the right ventricle, more blood going through the pulmonary arteries, so the pulmonic valve will take longer to close. Makes sense? تمام? Okay, I guess everything is okay. We can move on to the abnormal heart sounds. Now, we said we have S1 and S2 being the normal sounds. Now we have S3 and S4 for the abnormal sounds, and we also have a couple murmurs to talk about. But for now, let's start with S3. S3 is a low pitch heart sound. So compared to S1 and S2, it's low pitch, and it's an early diastolic gallop. So it sounds like horses. So it's an early diastolic gallop. What did we say about S3? We hear S3 just after S2. So it's heard in the rapid ventricular filling phase. We said S2 is heard when the ventricles start relaxing. So the aortic and the pulmonary valve would close. Now, when the heart starts filling with blood, you would hear S3 due to volume overload. I want you to remember very well. S3 is due to volume overload. Now, when do we hear S3? We said S3 is an abnormal heart sound. However, we can hear it sometimes in a normal person, no pathologies, so physiology. So it could either be physiologic or pathology. Meanwhile, S4 is always abnormal, always pathologic. S3 could be normal in children, in athletes, and in pregnancy. Now, in children, in the case of children, especially if they're thin and tall, it would be due to increased muscle movement with every heartbeat. So this increased movement would enhance the sound of the heart filling. So it's normal in children. Moving on to athletes, athletes would have an enlarged heart. Now, due to the continuous training and the continuous pumping of the heart would start to adapt. Now, we'll talk further about this point in a few slides, but for now, just remember that the heart would start enlarging, so the sound of the filling of the heart would be enhanced. So this is, again, an S3 heart sound. And finally, in pregnancy, we said S3 is due to volume overload. So in pregnancy, there's increased volume, which would give us an S3 heart sound. So these are the three cases of the physiologic or normal S3. Now, moving on to the pathologic. It would be abnormal in the case of aortic or mitral valve regurgitation. Regurgitation is basically when the valve is incompetent. So this is the normal heart. The blood would go through the vena cava, right atrium, right ventricle, then come to the pulmonary arteries, comes back again to the left side of the heart, left ventricle, and then when the heart contracts, it would push blood through the aorta, through the aortic valve, and then when it starts relaxing, the aortic valve would close. Now, in the case of aortic regurgitation, this valve is incompetent, so it does not close properly. So it would stay open a bit, so blood would go back or leak back into the ventricle. So you can imagine the heart relaxing, it's expecting blood only from the ventricle, but now it's receiving blood from the ventricle and also from the aorta. So there is volume overload. Hence, S3 heart sound. Tamam? Is that clear?
So the mitral valve will be open or closed?
So in the case of, usually when the heart is relaxing, the mitral valve would open to allow blood to go into the ventricle. But in this case, in aortic regurgitation, the aortic valve would not close properly. So now, together with the filling of blood from the atria, we also have filling from the aorta. So now there's volume overload in the ventricle. So this would give us an S3 heart sound just after S2. Is that clear?
Yes, thank you.
So, now moving on to S4. S4 is another abnormal heart sound that is always pathologic. It's never normal. So this is, again, a gallop rhythm, just like S3, but it's heard just before S1. So going back to this slide. Okay. So you can see S3 is here after S2. S4 is just before S1 during atrial systole. So let's, sorry, yeah. So during atrial systole, you'd hear S4. And what is the cause? We said S4 is due to pressure overload, not volume overload. So in this case, the ventricle would be less compliant. What does that mean? A less compliant ventricle would be stiff. So let's imagine and the atria are now contracting. They're pushing blood into the ventricles. So now if the ventricle is stiff, it's not flexible, it's hard, you could hear the sound of blood hitting the ventricle. So you can imagine it, instead of hitting a pillow, you'd hit a table. So the sound would be enhanced. So you'd hear an S4 heart sound due to pressure overload. For example, if the ventricle is less compliant. And when is it less compliant? If there's chronic hypertension, for example. So if there's increased blood pressure in the body, the heart would be exerting a lot of force, a lot of pressure to be pumping blood all around. So when it's exerting this much pressure, the ventricles would start to adapt. So we have ventricular hypertrophy. So ventricular hypertrophy is when the muscle would thicken. We'll be talking about it in the next slide. So due to chronic hypertension, the ventricle will become less compliant, so it becomes stiffer. So it need an S4 heart sound due to the hitting of the blood when the atria is contracting. Is that good so far? And we have another case. Yes.
What does gallop mean?
Gallop is the sound, for example, the horses make. So it would be an abnormal sound. So instead of having the normal S1 and S2 sound, you'd hear something different. You'd hear a gallop rhythm, which is like the horses, and it would be more low pitch. So,
Okay.
now this would be heard in the case of ventricular hypertrophy and in aortic stenosis. Now you can see here in aortic stenosis, here normally the valve would open normally because the valves are fine, but in aortic stenosis, the valves would not open properly. They're stiff and they're not opening properly. So now you can imagine the ventricles when they contract to push blood, the valve is not open properly, so it can't push blood. So it would try harder. So it would increase the pressure to pump against the stiff valve. This would give us an S4 due to pressure overload again. Is that clear? So S4, pathologic always, due to during atrial contraction, due to aortic stenosis and ventricular hypertrophy. Now, speaking of hypertrophy, we have two types of hypertrophy. We have concentric and we have eccentric hypertrophy. What is the difference between them? So this is the normal heart. You can see the muscle wall, you can see the volume of the left ventricle. Now, what happens in the concentric hypertrophy is that there is high pressure. So just like I explained a few minutes ago, there's reduced compliance. Why? Because there is an increased afterload. So the ventricle would be pushing blood against high pressure. So it would start working harder. So it would push the blood against this pressure. So this would cause a reduction in compliance. Now the muscle wall would start thickening. So the muscle fibers would become thicker and they would be haphazardly arranged to adapt to this increased pressure. This would give us an S4 heart sound. So this heart sound could be a result of chronic hypertension and aortic stenosis, as I just mentioned. So if the ventricle is trying to push blood against a stiff aortic valve, which is aortic stenosis, or if there's chronic hypertension in the body and the ventricle has to exert more pressure to pump. So this is a pressure issue, basically. Concentric hypertrophy is found when there's a pressure problem. So which heart sound would you have? Is it S3 or S4? Have S4 because we said S4 is related to pressure. So you can imagine this 4. This is the pen. So this is the 4. You can imagine it as a flipped P, for example. So P for pressure. So S4 is due to a pressure issue. Tamam? Okay, so this is for concentric hypertrophy. Now we have eccentric hypertrophy. Eccentric is due to increased preload. Now we have, instead of having high pressure, we have high volume inside the channel. So if you can imagine, if the ventricle is filling with too much blood, you have increased volume inside the chamber. What would happen? it would start expanding. So you have eccentric hypertrophy increase in the diameter, and there may or may not be wall thickening, but the main issue here is the diameter increasing. Now, when do we have this? In athletes. Remember when I said their heart would start adapting due to the continuous training? So this training would cause eccentric hypertrophy. The heart would be filling with more blood. You have volume overload. We said volume overload is associated with which heart sound, abnormal sound? S3. Now S3, it's fine. Now we said S3 is associated with volume overload. For example, in athletes, but in athletes it's reversible. So if they stop training, after some time the heart would go back to normal. But sometimes it's pathologic and irreversible. For example, in regurgitation. So if the ventricle is contracting and then when it's relaxing, it's receiving blood from both the atria and the aorta. There will be volume overload, so it starts expanding. We have eccentric hypertrophy. Now again, you can imagine the 3 as an E. So S3 is related to eccentric. Meanwhile, we said S4 is a pressure issue, so it's related to concentric hypertrophy. All good? Any questions?
Yes, I have a question.
Yes, of course.
What does concentric, eccentric mean? The word itself.
Okay, the meaning of the word itself, I'm not really sure, honestly. I will search and let you know. But for now, just remember what it stands for. Eccentric for increase in diameter, concentric, increase in the thickness of the wall. So,
Okay, gotcha.
okay. So, any other questions? So, okay. Now we can move on to the heart murmurs. So again, these are additional sounds you hear during auscultation, but this sounds due to turbulent blood flow. So if there's a problem with the valves, for example, let's say there's a stenosis or there's a regurgitation, there will be a turbulent flow. So instead of moving like parallel and laminar flow, the blood will not be moving in a ranged way, which is called turbulence, and this would give us a heart murmur. Now, murmurs can be classified into systolic and diastolic heart murmurs. Systolic, from the name, would be due to ventricular systole. Due to the contraction of the ventricle, or during the contraction of the ventricle, you would hear this heart sound. Diastolic, meanwhile, would be heard when the ventricles are relaxing during diastole. So for systolic murmurs, we have aortic stenosis, mitral regurgitation, atrial septal defect, and ventricular septal defect. For diastolic murmurs, we have the aortic regurgitation and mitral stenosis. Now, of course, when I say aortic, we mean aortic and the pulmonary. For the mitral, we mean mitral and tricuspid. So imagine it as semilunar valves and the atrioventricular valves. Now, we'll be explaining everything. So we said S1 heart sound is heard when the ventricles, sorry, okay, S1 is heard when the ventricles start contracting. So the mitral and tricuspid will close. So S1 is due to the closure of AV valve, and it marks the beginning of systole. Meanwhile, S2 is heard when just when the ventricles start relaxing. So it marks the beginning of diastole. Does that make sense? Come on. Okay, great. طيب, between them is whatever, if you hear any additional sound between S1 and S2, this would be a systolic murmur. If you hear anything after S2, since S2 marks the beginning of this diastole, anything after S2 would be a diastolic murmur. تمام? So for example, we have aortic stenosis and mitral regurgitation. These two are heard between S1 and S2, so they're systolic murmurs. Meanwhile, we have aortic regurgitation and mitral stenosis being the diastolic murmurs. We'll be explaining every one of them shortly. But for now, to remember the different classification, just keep in mind that aortic stenosis is a systolic murmur, and then you can easily classify the rest. So you have one stenosis and one regurgitation for systolic, and you have one stenosis and one regurgitation for diastolic. If you remember that aortic stenosis is systolic, you can remember the rest. But now we'll be explaining them in detail, and it would be so easy to remember. It's fine. So now we can move on to the valvular disorders and if they're systolic, diastolic, and how they affect the PV loop. But for now, is everything okay? Any questions? Done. Okay, we can move on. The valvular disorders. We start with the mitral or tricuspid regurgitation. Now, this is a systolic murmur. If we can't remember if you can't remember the classification, you can't remember if it's systolic and diastolic, just imagine what's happening with the heart. Now, this is one thing that's really good about CVP. Now, compared to foundation, for example, compared to other blocks, this block does not really focus on memorizing stuff. So you'd understand, you'd be able to solve questions if you can just imagine, if you can visualize the heart in front of you, and the different, whatever is happening in the heart, if you can just visualize it and imagine it in front of you, you can easily solve the questions. You don't have to memorize anything. So this is one thing that I really love about CVP. So make sure you know the anatomy well, understand the physiology, and whatever is abnormal, all those pathologies would be easily figured out this way. So let's imagine the regurgitation. Regurgitation is when the valve is not competent. So the valve is not closing properly. So here we have the atria would be filling with blood going into the ventricles, and now the ventricles start contracting. Instead of pushing blood only to the aorta, the mitral valve is not closing properly. So blood would go back to the atria too. So this is a problem when the ventricles are contracting. So ventricles contracting means systole. So it's a systolic murmur. So we have a problem when the ventricle is contracting because the blood is leaking back from the ventricle to the aorta, to the atrium, instead of only going into the aorta. Makes sense? So it's a systolic murmur, and as you can see here, it's between S1 and S2. So how does this affect the PV loop? Before getting to the mitral regurgitation PV loop, let's review the normal PV loop. Here, on the x-axis, we have the left ventricle volume. Y-axis, we have the pressure. So here, as you can see, there's filling of blood. So the ventricle is filling with blood. Now, the mitral valve would close. The ventricle would start contracting, but both valves are closed. So we have isovolumetric contraction. So at this point, the ventricles would be fully, the maximum volume of blood is in the ventricles. So this is the end diastolic volume. So by the end of diastole, this is the volume we have, end diastolic volume. Now the ventricles start contracting, aortic valve is open now. We have ejection. So the blood would be leaving the ventricle and going all around the body. This marks the end of systole. So this is systole. By the end of systole, we have this much blood left in the ventricle. So this is the end systolic volume. Here we have the end diastolic volume when the ventricle is done filling with blood. Here we have end systolic volume after the ejection. So all the blood has left, all the stroke volume has left. So what is the stroke volume? Stroke volume is basically whatever is pumped from the blood, from the heart. So it's the difference between the end diastolic volume and the end systolic volume. Tamam? This was just a quick PV loop review. Do you have any questions about the PV loop?
Excuse me.
Yes.
I don't have a question about the PV loop, but I had a question about the what's it called, the hypertrophy from before.
Okay. This. Here.
Yeah. Is it correct that eccentric hypertrophy leads to S3 sounds?
Yes.
Okay, so I had a question. Basically, isn't eccentric hypertrophy like making more space for the more diastolic volume?
No, look, this is a form of adaptation of the heart. This is not just accommodating more volume. This happens over a period of months. So it happens over a long period of time because the heart is continuously filling with more volume. It's not something that is just transient for a short period. So it won't just accommodate this volume and then move on. No, it would be continuously happening due to valve regurgitation, for example. So it would be continuously happening. And now the ventricle would start adapting. So it would increase in diameter but the fibers themselves will not be normal. The structure of the heart will be affected. And we said sometimes there will be also wall thickening. So it won't only be increase in diameter. In some cases, you'd also see wall thickening. So this is something pathologic. This is something abnormal. So you would hear a heart sound. But obviously, the heart sound won't be in all cases. But S3 is related to eccentric hypertrophy.
Okay.
Exactly.
Thank you.
Of course. Now, we were talking about the PV loops. We talked about the normal PV loop. Now, what would happen if there's a change in the compliance? Now, what does the word compliance mean? A person who's compliant, for example, would listen to the orders. So they're compliant. So, for example, if we want to fill the heart with blood and we're adding pressure, a compliant ventricle would expand and accept this increase in volume, for example, increase in pressure. So so you can see here, for example, let's say we want to fill the blood, we want to fill the heart with, for example, 60 milliliters of blood. So this is a normal compliance. If the ventricle is more compliant, this would mean that the ventricle would expand more. It's not stiff. So you would need less pressure to achieve this volume. So if we want to fill the ventricle with 60, let me get here. Let's say we want 60. So here we have normally you need, for example, let's say 10 millimeters of mercury. But if the ventricle is compliant, you need less. You need only 5, because the ventricle is not stiff. It's accepting this change in pressure. So this is increased compliance. Meanwhile, in the case of decreased compliance, the ventricle would be more stiff. So you'd need increased pressure to reach this volume. So instead of 10, you'd need 20, for example. Does that make sense?
Can you repeat it again, please?
Yes, of course. Let me use everything. So this is the normal ventricle. Tamam? This one. Sorry. The one in the middle is the normal one. So now, let's say the ventricle is more compliant. Let's imagine the ventricle pumping the blood. If the ventricle is more compliant, it will be less stiff. So only a bit of pressure would allow it to expand and fill with blood. So, okay. We said we want, for example, 60 milliliters of blood to fill the ventricle. Now, let's imagine if the ventricle is less stiff, you won't need that much pressure to reach this volume. You'd need only a little bit of pressure, and the ventricle is compliant, so it would allow more blood to come in. So instead of needing this much pressure, you'd need less pressure because the ventricle is now less stiff, so it's accepting this change. Meanwhile, if there's decreased compliance, the ventricle is stiff, so it's hard to fill it. So if you're trying to add pressure, it won't expand and accommodate this change. It will be less accommodating, so you need much more pressure to fill it. So instead of needing this much pressure, you'd need much more to reach the same volume. Does that make sense?
Yes, it does. Thank you so much.
Of course. Tamam. Okay, so now we review the PV loop. We can go back to the mitral regurgitation. So this is the PV loop for mitral regurgitation. The black outline is the normal PV loop, and this red thing is mitral regurgitation. So let's imagine it step by step. So we said the valve is not closing properly. The mitral valve, this is the mitral valve. So when the heart is contracting, the blood, instead of leaving only through the aorta, now has a second path to go. It can go to the atria too. So by the end of systole, more blood has left the ventricle. So more because blood can now go through the aorta and through the atria and to the atria too. So more blood has left. So by the end of systole, will we have more volume inside the ventricle or less volume?
Less.
Exactly, we have less. So so here we have decreased end systolic volume. So by the end of systole, because blood has went through 2 ways, we have decrease in end systolic volume. Now, what about the end diastolic volume? The end diastolic volume would increase because when the ventricle is filling, it's It's increasing in size. Now the mitral valve, we said it's incompetent, so it would allow more blood to come in. So now we have an increase in end-diastolic volume. We have a decrease in systolic volume. So what happened to the stroke volume we have here? We said the stroke volume is the difference between ADV and ESV, difference between end diastolic volume and end systolic volume. So the stroke volume would be
Increased.
exactly. So now we have an increase in stroke volume, but one thing you have to note. Now the total stroke volume would increase because blood can go through two ways, we said. But the effective stroke volume is the amount of blood that actually reaches the heart, the rest of the body. So the effective stroke volume would actually go down because now instead of only going to the aorta, to the body, now it's going to the atria, which technically does not go directly to the organs we need. So the effective stroke volume would go down because there's another pathway, although the total stroke volume went up. Does that make sense? Okay, someone's asking me to repeat. طيب. We said the heart would be pumping blood. So during systole, blood will the mitral valve would not close properly. So now blood would not only go through the aorta, it would also go through the atrium. So now we have two pathways for the blood to go. So the total stroke volume, the amount of blood that leaves the heart, that leaves the ventricle, is increased. But is it increased and all going to the organs? No. Some of it is only going to the atria, and only a part is going to the organs. So the effective stroke volume is less because now we have another pathway for the blood to go. But the total stroke volume increased because more blood is leaving the ventricle, but not all of it is going through the aorta to the organs. So the effective stroke volume is actually less. تمام? Now, what type of hypertrophy do we have here? We said regurgitation would lead to eccentric hypertrophy because when the ventricle is filling with blood, we'd have more blood going inside. So this is a volume overload issue. Volume overload would give us which heart sound? S3 heart sound. Said volume is rated to S3, and we have eccentric hypertrophy. تمام? Is mitral and tricuspid regurgitation good? And diastolic volume is ventricular filling, not atrial filling. So let's go back here. So this is the left ventricular volume. So the left ventricle will be filling with blood, and by the end of diastole, you have the end diastolic volume. No other questions? We can move on to aortic stenosis, aortic or pulmonary stenosis. Now again, we said this is a systolic murmur, but let's understand what's happening to visualize the structures in front of us. Stenosis is basically stiffening of the valve. Instead of being too compliant, we have a stiff valve that does not open properly. So you can see in the image here. So this is a healthy valve, but a stenotic valve would look like this. It's not opening properly. So when the heart is contracting, trying to push blood, it can't push blood effectively against the stiff valve. So this is a problem during the contraction of the ventricle. During the contraction means systole. So what type of murmur do we have? A systolic murmur. So aortic stenosis is a systolic murmur. And you can see here in the diagram, it's between S1 and S2. Now, this has a specific pattern. We call this a crescendo-decrescendo pattern. So you can see the heart sound getting louder, and then it's going lower. So this is specific for aortic stenosis. So whenever you see this pattern, think of aortic stenosis. So it's a systolic murmur between S1 and S2, and it has this pattern, goes up and goes down. So what did we say about it? Blood cannot pass from the ventricle to the aorta, or in the case of pulmonary stenosis, from the ventricle to the pulmonary artery. So what are the changes in the PV loop? Let's imagine it. Okay, the heart is trying to pump blood, it's trying to push against a stiff aortic valve, and it can't. So what would happen to the volume? The volume by the end of systole, do you have more volume inside the ventricle or less volume? Anyone knows? Because someone is saying less. Any other answers? Increased, decreased. Okay, so having more answers. Increased ASV, yes, correct answer. Okay, so by the end of systole, okay, the ventricle has contracted. It's time to push blood, but blood cannot leave through this valve. So not enough blood has left the ventricle. So by the end of systole, the end systolic volume would be higher. So you can see here, we have an increased end systolic volume. So you have more blood still left in the ventricle because it can't pass through the stiff aortic valve due to the stenosis, aortic stenosis. So what would happen to the stroke volume? Stroke volume, which is basically the amount of blood that has left the ventricle, stroke volume would be decreased because most of the blood, not most, a certain volume of blood is still left in the ventricle. It hasn't left the heart. So stroke volume would be decreased and systolic volume is increased. This is the normal one. This is due to aortic stenosis. But you can see there's a huge increase in pressure because the heart is trying to push against this ventricle. So there's a huge increase in pressure to overcome this obstacle. So you can see the pressure here by the end of systole is so high. Instead of the normal 120, you can see here it's reached 200. So this is a pressure issue. So what type of hypertrophy do you think we have? Concentric or eccentric? Yes, okay. Tamam, great. So we have concentric hypertrophy because the ventricle is working hard to push against the stiff valve. So there's decreased compliance. A pressure issue would lead to concentric hypertrophy. There's thickening in the muscle wall. So now we have an S4 heart sound. So S4 is associated with concentric hypertrophy and the pressure overload. So that's all for aortic stenosis. Again, aortic or pulmonary, so the semilunar valves. Now to the regurgitation, to the aortic regurgitation. Now we said we have aortic stenosis and mitral regurgitation for the systolic murmurs. So now we have aortic regurgitation with the diastolic murmurs. But again, we don't want to memorize, we want to understand. We want to understand what's happening. So the heart, okay, what does the word regurgitation mean? Regurgitation means the valve is incompetent. The valve is not closing properly. So blood would flow back from the aorta to the ventricle. Now, when would this happen? Normally, when the heart contracts, it would push blood into the aorta. Now, the heart is done contracting, done pumping blood to the body. So it starts relaxing, being diastole. And now, instead of receiving blood only from the atrium, you'd have blood coming back from the aorta. So this is an issue that we face when the ventricles are relaxing. So this means being diastole. So this is a diastolic murmur. So you can see in the diagram here, you hear this murmur after S2. So we said anything after S2 is a diastolic murmur. So this is the pattern for aortic regurgitation. We have a leaky aortic valve. Blood flows from the high pressure in the aorta to the low pressure in the left ventricle. Tamam? Now we have the PV loop. What would we expect? We said it's a diastolic murmur. The heart, when it's relaxing, it's filling with blood. Instead of blood coming only from the atrium, it would be coming also from the aorta. So by the end of diastole, you'd have increased volume. So the end diastolic volume would rise. So you can see here, this is the normal end diastolic volume, and this is the new one. So by the end of diastole, you'd have more blood in the ventricles because instead of coming only from the atria, it would also come from the aorta. So end diastolic volume is increased. Systolic volume is also increased. Now let's imagine the heart. Now it's trying to fill with blood. It's filling with blood from normally only from the atrium. Now it's filling from two places. So we have volume overload. Volume overload is associated with an S3 heart sound due to what? It's eccentric hypertrophy. So eccentric hypertrophy happens when there is too much blood filling, volume overload, so we need the S3 heart sound. Now, what does this point mean? We have an increased systolic blood pressure and decreased diastolic blood pressure. Let's imagine what's happening in the heart. the heart is now filling with too much blood. So when it's pumping blood, you'd have more volume leaving. So the systolic blood pressure, if you measure it, would be increased. Systolic blood pressure would be high because you have more volume leaving the blood. But now, when the ventricle is relaxing, the heart is relaxing, blood, instead of continuing its way, it's going back through the aorta into the heart. So you have less blood continuing its pathway. So you have diastolic blood pressure will drop. So you have a widened pulse pressure. Pulse pressure is the difference between the systolic and the diastolic blood pressure. So during systole, you'd have an increased blood pressure. The systolic blood pressure would be high. The diastolic blood pressure, meanwhile, would go down because the blood is going back through the aorta instead of continuing its way. So now we have a widened pulse pressure. Does that make sense? You can type in the chat. Any questions? So good. So now we can move to the final valve issue. We have the mitral or the tricuspid stenosis. Now the mitral or the tricuspid stenosis is again a diastolic movement. So it's heard after S2. Now you can see we have one characteristic feature, which is an opening snap. So when you hear the mitral stenosis, the sound of mitral stenosis, you'd hear a snap first, and then you'd hear the murmur. But for now, just focus on the fact that it's a diastolic murmur. Again, we want to understand why is it a diastolic murmur. So now, stenosis means there's a stiffened valve. The valve is not compliant enough to allow blood to pass. Now, when do we want blood to pass from the atria to the ventricles? Is it during contraction or during relaxation? Any answers?
Contraction.
Usually during contraction, we don't want blood to move from the ventricle to the atrium. We want it to go to the aorta. During relaxation, though, we need the blood to go from the atrium into the ventricle. But here we have a stiff valve. We have a stenotic valve. The mitral or the tricuspid valve would be stenotic. So it won't allow blood to pass from the atrium to the ventricle during diastole, when we want the blood to actually go from the atrium to the ventricle. So this is a diastolic murmur. So during diastole, the blood would be struggling to pass through this narrowed valve. You can see here, it's very narrow. So now blood is struggling to pass through. So we have a larger than normal pressure difference between the atrium and the ventricle. So the volume of blood would be concentrated in the atrium. It won't reach the ventricles during diastole, hence diastolic murmur. Now to the PV loop. This is the PV loop for mitral stenosis. We said there's a problem during diastole. The heart is trying to relax, trying to fill with blood. So now, when it's trying to fill with blood, the blood cannot pass through the stiff valve. So by the end of diastole, do we have enough blood in the ventricles, or is it decreased, or is it increased? Any answers? Decreased, exactly, yes, thank you. So by the end of diastole, we have less blood filling the ventricle. So we have decreased end diastolic volume. We said this line is for diastolic volume, to have decreased end diastolic volume. So what happened to the stroke volume now? The difference between those two lines is the stroke volume. So the stroke volume is decreased. Let's imagine it. Now we have the heart. The heart is now the ventricle is full of less blood due to the stenotic valve. So when it's contracting, it's pushing less blood through the aorta. So you have less stroke volume, less blood has left the heart. That is due to the decreased end diastolic volume. Makes sense? Tamam. So now let's imagine the volume of blood that was supposed to fill the ventricle would now fill the atria. It would be stuck in the atria. So there's increased volume in the atrium. So what type of hypertrophy would we see in the atrium? We have increased volume in the atrium. So you would see.
Concentric.
Yes, exactly. So we have eccentric atrial hypertrophy. So the P wave would be abnormal. Now, I'm not sure if your doctor emphasized on this point, but a normal P wave, I'll just be going over it briefly. So this is the normal P wave. We have we said the P wave is due to the atrial depolarization. So this would affect the atria contracting. Now the beginning of the P wave would be related to the right atrium. The last half would be related to the left atrium. So P wave would be abnormal depending on which atria is affected. So if the left atrium is affected, you have the second half would be bulging. So you would see kind of a humped shape for the P wave. Meanwhile, if you have right atrial hypertrophy, you'd see the whole wave being enlarged. Now, you'd focus more on this in the third year, because this was mentioned in your slides, so I thought I'd mention it now. But I'm not sure if this is hard, honestly. Now, we said this is a diastolic murmur because there's turbulence when the ventricle is trying to fill with blood, but the valve is stenotic. But there's no problem with the ventricle itself. The ventricle is not overfilling. There's no changes in the compliance, so you won't hear an abnormal sound, like an S3 or an S4 heart sound, but you would hear a diastolic murmur, which is due to the mitral stenosis. So we mentioned all four abnormal heart sounds. We said aortic stenosis and mitral regurgitation are systolic murmurs. We talked about aortic regurgitation and mitral stenosis for the diastolic murmurs. Do you have any questions about any of those? About the PV loops, about the valves, about anything at all? Tamam? I'm assuming you have no questions. But now that I talked about ECGs, there's something that was mentioned in your slides, but I'm not sure if it's also important for the hypertrophy. We also have changes in the ECG due to hypertrophy. Now, it was mentioned in your slides, but again, I'm not really sure if it's high yield, so I'll just explain briefly. We said hypertrophy is maybe due to the thickening of the wall. There's abnormality in the ventricular wall. So this is a normal ECG. These are the precordial leads. We have V1 to V6. And when placed on the chest, they'd be in this following arrangement. V1 starting from the right side, then we move on to V2, and going from V2 to V6 till the axilla. So normally, the heart axis would be this way. I think you guys can see my cursor, so okay, so the heart would be moving this way. So the ECG, so the pattern in V1 would be negative because it's moving opposite to lead V1. Meanwhile, in V6, it would be moving towards V6. So the wave would be positive. The deflection would be positive in V6. What if we have left ventricular hypertrophy? So this is the ventricle, and this is the left ventricle. If it is hypertrophied, the conduction or the impulse would spend more time at this side. So you can imagine it as the conduction is passing through, instead of moving, distributing fairly, it would spend more time at the hypertrophic area. So it would spend more time here. So you can imagine the impulse would spend more time at the left side. Is this closer to V1 or V6? In this case, it's closer to V6. So you'd see a greater positive deflection in V6. Meanwhile, in V1, it would be more negative because the impulse is spending more time at that side. What if we have a right ventricular hypertrophy? This part of the heart would be enlarged. Now, the wave would be spending more time, or the impulse would be spending more time at this direction. So it would be going away from V6. So V6 would be less positive. Meanwhile, it's closer to V1. So V1 would be more positive than normal. Normally, V1 is more negative, V6 is more positive. But if we have left ventricular hypertrophy, V6 would be more positive. If we have right ventricular hypertrophy, V1 would be more positive. Now, again, as I said, I'm not sure if you guys have to go into details about this, but since it was mentioned in your slides, I thought it would be good to include. So now we can go back to our presentation. Please stop here. Do you have any question about the valves and regurgitation? And the stenosis and everything? can type in the chat. تمام. Okay. So I'm assuming there's no questions. So we can move on to the last part. Alhamdulillah. We only have the few questions left, and then we'll be done with the presentation. Okay, here's our first question. Patient has an episode of syncope and was brought to the hospital by his son. When regaining consciousness, he complained of chest pain and difficulty breathing. He was referred to the cardiac lab where an echocardiogram was made and showed a murmur. What type of murmur is shown? You can type your answers in the chat. Yes, mashallah. A lot of C's. I see a lot of C's. Yes, good job. Okay, correct answer is aortic stenosis. So, you can see here the murmur is heard between S1 and S2. So this is a systolic murmur. Now, a systolic murmur, we have aortic stenosis and we have mitral regurgitation. So we removed A and D. We eliminated A and D. So now we have mitral regurgitation and aortic stenosis. Now we said this up and down pattern, this crescendo decrescendo pattern is typical for aortic stenosis. And you will learn with practice this scenario of someone who was, for example, you'd see a typical scenario of an old man who was shoveling snow and then suddenly fainted, or an episode of syncope. Now, this scenario is also typical for aortic stenosis. So whenever you see this crescendo decrescendo pattern and the patient who was, for example, the example our doctor gave us was an old person shoveling snow and then suddenly fell unconscious. So this is typical for aortic stenosis. Now, second, which of the following causes a diastolic murmur and produces an S3 heart sound? Well, I see an A. Other answers? A few more answers and I don't know. I have an A, we have a C. Others, what do you think? Tamam, no other answers? Clear. Correct answer is A, pulmonary regurgitation. Now, we said we want a diastolic murmur. So what are the diastolic murmurs we have? We have mitral stenosis and aortic regurgitation. Aortic or pulmonary, mitral means mitral and tricuspid. So why is pulmonary regurgitation the answer? Let's go back to the slides. Mitral or tricuspid stenosis. What did we say about it? There's an abnormality because the atria are filling with blood, and they're not letting this blood go back to the go to the ventricles. So the ventricle itself won't have a problem. And we said there's no overfilling or compliance changes. So we won't hear an S3 or an S4 heart sound. Meanwhile, in aortic regurgitation, this is aortic regurgitation, we would hear an S3 heart sound, and this is a diastolic murmur. So you can see, you can hear this after S2, and you can hear an S3 heart sound. So the correct answer would be aortic or pulmonary regurgitation. Now, we have the final question. Patient comes in and you listen to her heartbeat. There's an apparent splitting of S2 heart sound accentuated by inspiration. Which of the following is her diagnosis? Here we have a couple of these. Other answers? I have an A, I have a B. تمام. Okay. Correct answer would be normal findings. Let's go back to the start. So, the start. This is the S2 method. We said S2 is due to the closure of the aortic and the pulmonary valve. So the semi-pulmonary valves for S2. Now it would be normal if the aortic valve closes before the pulmonic valve, which is enhanced during inspiration. Abnormality is not accelerated during inspiration. Only if it's normal, it would be enhanced during inspiration. Meanwhile, if we have a bundle branch block or an atrial septal defect, this would be a problem with the structure of the heart itself. So breathing will not really affect the whatever is happening. It won't affect. Sorry. Okay. So breathing would not affect the atrial septal defect or the bundle branch block. Now, we said the patient had a split S2, which was accentuated during breathing. So this would be a normal finding. تمام? Is the question clear? Okay, now we're done with the presentation. Thank you so much for attending. But sorry, before you leave, I just want you to scan this QR code. I'll just add it quickly.